We're going to talk a little bit about empathy and compassion. It's a continuation of themes that you've heard previously from Dr. Coulihan's excellent presentation on the good doctor. This is one of my favorite pictures by Norman Rockwell. The golden rule, do unto others as you would have them do unto you. Still, in my view, the greatest moral precept ever created because of the way it forces us to use our moral imaginations, asking ourselves, how can we contribute to the well-being of those around us? And you notice this is 1961 when Rockwell painted. It was the cover of the Saturday Evening Post, no relative, by the way. And you've got people from every religious tradition. You've got that secular existentialist maybe in the middle with his denim jacket on, rubbing his chin. You've got males and females. You've got old and young. Everybody gathered together. Thinking not minimally. Doesn't take much to follow the negative version of the rule. Do not do unto others as you would not have them do unto you. Everybody can go home tonight and feel pretty good about their lives if they didn't elbow their peer in the ribs. That's minimalism. This is moral idealism. This requires more. And this is what Rockwell is trying to say. He insinuated this into American culture really 6 or 7 years before the civil rights movement really started to push forward. So he was way ahead of his time. And you'll notice that he captured something. If you look at the faces of these individuals, there's a kind of a serenity and a calmness about them. We now know from lots of good studies that when people just focus their minds on helping others, even on giving a donation, their mesolimbic pathway gets active, which is the center of feelings of satisfaction and joy. They dole out one of the 4 happiness chemicals, dopamine. And there's also probably some oxytocin involvement, and that's the compassion hormone that's mainly connected in behavioral endocrinology with feelings of inner serenity. So he captured all that in this incredible picture, which is really one for the ages. And neuroscience now tells us, by the way, that when you're focused in this way, those neurological pathways tend to shut off the destructively emotional pathways, bitterness, hatred, and so forth. So there's a lot to be said there about human nature, at least the better side, and how we want to think about the moral life. The Dalai Lama has said when people are overwhelmed by illness, we must give them physical relief, but it is equally important to encourage the spirit through a constant show of love and compassion. It is shameful how often we fail to see that what people desperately require is human affection. Deprived of human warmth and a sense of value, other forms of treatment prove less effective. Sounds a little bit like old Harry Harlow and his monkeys in 1951 in Madison, doesn't it? They just don't thrive without a little warmth. This is Dame Cicely Saunders. Died in 2005. She was one of the most effervescent and generous people. For her, compassion wasn't an emotional state, it was an activity. She was Aristotelian in that sense. It was an activity in the world. The Dalai Lama has been critical sometimes of the way Americans think of empathy and compassion more as a satisfying emotional state than as a way of practicing life. She was a nurse, a social worker, eventually a physician. She founded the modern hospice movement. Her tours in the U.S. began in the early 60s. She invented this idea of total pain, of compassionate care as a way of addressing psychological, spiritual, and physical suffering in the terminally ill. She revolutionized the use of pain medication. By the way, hospice is not palliative care, right? Too many people are afraid to refer patients to palliative care because they think it's a death sentence. Actually, palliative care has nothing particularly to do with patients who are dying. It has to do with quality of life and freedom from pain and suffering, but it can be applied very widely. And here we have a Department of Palliative Care from which people sometimes are discharged to a hospice, right? So there is a big difference. I knew Cicely Saunders over the years, and in 1999, she gave a dinner speech at a conference in Cambridge, Mass, that I was co-chairing on the science of empathy and altruism. And she was there as an exemplar. So she stood up and she said, I'm 83. She'd come in from St. Christopher's Hospice in London, which she founded. And you know what? Every morning I go into St. Christopher's and I change bedpans for an hour. That struck me as kind of strange, but she said it was a mark of humility. And then I sit on the end of beds and I listen to people talk about their lives. And I ask them one big question. What was the most gratifying thing that you experienced? What meant the most to you? And she said, when you listen to people like that attentively and you don't interrupt them, it's an action of compassionate love. She was an absolutely amazing woman. I remember leaving that conference and I went home at that time to Cleveland, and I took a look again at the Buddhist physician's vow. I will minister to the sick with a mind of love, not out of desire for gain. And here you go. I will remain unmoved when I have to deal with stool, urine, vomit, or spittle, aka saliva. Even if I cannot heal a patient with the proper diet, proper medicine, and proper nursing, I will still minister to him or her out of compassion. St. Christopher's is a pretty simple place, still in operation, and it's really the home of the modern hospice movement because it's from St. Christopher's that the movement spread all over the world. She had two favorite quotes. One from the poet E.E. Cummings: "We do not believe in ourselves until someone reveals that something deep inside us is valuable, worth listening to, worthy of our trust, sacred to our touch." Very difficult for people sometimes to take care of themselves, to care about their health. But when you are compassionate and empathetic with them, then they begin to see that their life has some value and it's not just some cosmic mistake. And then she loved a famous quote from Kahil Gibran: "Work is love made visible." And for Dame Cicely, that was always the case. It was always her work as an action of love. Should we be so lucky? If you look at codes of professional ethics, the nurse in all professional relationships practices with compassion and respect for the inherent dignity, what does that mean? Worth and uniqueness of every individual. A pharmacist promotes the good of every patient in a caring, compassionate, and confidential manner. A physician shall be dedicated to providing competent medical care with compassion and respect for human dignity and rights. Respect coming from respectara, to look again, to look a little more deeply in what people are thinking and feeling and experiencing and maybe taking them seriously for a change. The first AMA Code of Ethics, 1847, for the physician should be the minister of hope and comfort to the sick. Minister of hope, get that. That by such cordials to the drooping spirit, he, she, may smooth the bed of death, revive expiring life, and counteract the depressing influence of those maladies which often disturb the tranquility of the most resigned in their last moments. Sounds a little bit like Dame Cicely, doesn't it? In terms of empirical studies, as far as patients and physicians are concerned in American healthcare these days, when it comes to compassionate care and empathy, the glass is both half full and half empty. So we have a ways to go. I'd like to make some distinctions, not necessarily steps. Routine care, you're always busy learning skill sets in clerkship environments, and that's really important. Get that butterfly needle in right the first time, please. That's one kind of care. When we talk about medical care, that's often what we mean, good medical care. Then there's cognitive empathic care, and these are not simple separations, but what some people refer to as detached concern. It's not terribly affective. It doesn't have that presence that Broyard is talking about in that wonderful essay of his that you read for today. And then affective empathic care, something that has a little more of the heart to it. Jody Halpern's article talks about that. And then compassionate care, which is more of an intensification of empathy under the conditions of suffering. So those are just some ideas. Now, is this practical? First question, do patients benefit from compassionate care? Well, it's certainly important in prevention. It's one of the keys to any kind of preventive intervention. We have a department of family, population, and preventive medicine that Dr. Granick is the chair of, and she can tell you a lot more about this than I ever could, but sure, it makes a big difference. And this is a cartoon that I borrowed from somebody. Resolutions, me, just what are you implying that I need to change? Well, buddy, as far as I'm concerned, I'm perfect the way I am. You know the story about the Zen Buddhist who approached the hot dog vendor, and he asked him, give me one with everything? Gave the guy a $20 bill, and there was no change for a couple of minutes. And the Zen Buddhist looked at the vendor and he said, well, where's my change? And the vendor said, change comes from within. It does. Motivational interviewing is all about change coming from within. You got to have compassion, acceptance, respect the patient's right to change or not to change, partnership, don't be an expert, looking down. Evocation, elicit ideas, have patients write them down on paper, do follow-up. All of this is key. But you can't help people change their behaviors in a world besieged by irresponsible activities of all kinds, epidemics of obesity and the like. We really have to work on this as a culture. Diagnostic benefits. 75% of patients are interrupted before they finish their initial statement. Listening and empathy result in more accurate diagnosis, and with practice, do not usually lengthen clinical encounters, with exceptions. 74% of medical errors involve cognitive factors like premature closure in differential diagnosis. It's not just a matter of, misarticulating something or bad handwriting or whatever it might be, but there's really an issue of premature closure. Adherence benefits. Adherence to treatment and planning correlates very highly with empathic care. In fact, it is the most predictive element when it comes to adhering to difficult treatments. Here's a study from Hojad at Jefferson Med in Philadelphia with diabetic patients. When they self-report that their physicians had high empathy scores, they have better glucose and LDL cholesterol control. One of my friends of many years, Toby Cosgrove, who is the CEO of the Cleveland Clinic, a heart surgeon, he wanted to know what gets people out of the clinic after heart surgery quicker, and caveat, healed. And it turns out that the most important predictor was whether they could self-report empathic care from their primary physician. It was nice to have a good team, but it was something special about that dyadic relationship between primary physician and patient that made all the difference. And yes, they were getting out of the Cleveland Clinic about 20% quicker, and happier and more satisfied as well. Non-adherence is common, and for you it's going to be frustrating. We were doing a reflection rounds last year for primary care, and there was one really great med student who actually started to tear up a little bit. He said, my patients, they don't do what we ask them to do, and it's so frustrating. Here I am spending my money, getting a medical education. How do I get people to take care of themselves? 50% on long-term meds, non-adherence, cardiac rehab, 20 to 30% on curative medications, 40% on dialysis. That's an old dialysis machine, a big vat with a plastic coil in the middle of it. It's actually from the Manhattan Dialysis Center, and it goes back to the mid-'70s. I worked there 13-hour shifts at night as a dialysis tech for about a year. And that was when Congress decided through Medicaid to cover all dialysis treatment. Well, I have to tell you that I learned very quickly that if I didn't treat these patients with some decent affective empathy, and you can pick that up in facial expression and tone of voice in the little details. Some of them never came back. They voted with their feet. And Norman Dean, who ran the Manhattan Dialysis Center, who was a nephrologist at Columbia University, he actually did a study, and he recognized that it was generally the poor and the odoriferous and sometimes the addicted who were the ones who would just leave, and we never saw them again, and they died. So there's a lot of importance here. Difficult patients, I don't use the concept. I think it's a bad idea. Generally, as recent literature points out, and there's a lot of it now in the major journals, it's about difficult relationships with the provider, with the system, with insurance. We all have, there's a book out by a couple of great neuroscientists, we all have blind spots, hidden biases of good people. We use dehumanizing words of microaggression. That's a whole field in the study of racism now. Have these patients experienced errors? Have their symptoms been blown off? Do they come with legitimate needs for pain treatment, but we're just viewing them as really addicts? So you want to value difficult patients because they're an opportunity for you to test your empathic care. Look at them in that way. Physical benefits. A lot of you are interested in the placebo effect, and you think, well, it's just, what your mind is thinking that shapes the outcome. Actually, recent studies and really good studies point out that a lot of the placebo effect is due actually to warm interpersonal relationship independently from what someone might be thinking. Abrupt dismissive interactions elevate stress and slow wound healing. This is in the field of psychoneuroimmunology. 40 seconds of compassion reduces anxiety. There is something called stress cardiomyopathy. Japanese expression for that is takotsubo. Weakening of the muscular portion of the heart triggered by emotional stress, protracted anxiety, death of a loved one, etc. Well recognized as a cause of acute heart failure, lethal ventricular arrhythmias, and rupture. So Maiden Golubic, who directs the Cardiac Lifestyle Intervention Program at the Cleveland Clinic, says, quote, when you're feeling hostile, your autonomic nervous system goes into overdrive. Your system is flooded with stress hormones, and if it happens often enough, those hormones can actually change the physiology of your heart. Dr. Mark Sullivan, is that true? Second-year resident in the heart clinic. Lowering patient stress. Some of you, I don't know what your fields have been in life. You're not all just out of college, but maybe you took the Minnesota Multiphasic Personality Inventory. Have you heard of that? The MMPI. Some of you take it. Go into counseling, psychology, pastoral care, whatever it might be. It's about 350 questions, all yes, no. You answer them, and you sit down with an advisor, a mentor, and basically it gives you an inventory of your emotional strengths and some of your areas for potential caution and even remediation, right? So it's been around since the late 1930s. It's still the gold standard. Redford Williams, the former head of cardiology at Duke, not anymore, is still emeritus, though, and around and being active. He took 27 questions from these 350, and he called it the hostility scale. Google it, 25,000 references to its use in contemporary cardiological research. Quickly angered, easily agitated, ruminating, right, unforgiving, uncaring, sharp, prone to violence, whatever. And then he did something really creative. This is the mid-1990s. He looks back at 1950, at all the people in the United States who have taken the MMPI and who at that time, 1950, were 25 years of age. And what he does is he follows them, because this data, a lot of it anyway, had been recorded. He follows them until 1975, when they are now 50 years of age. And lo and behold, the high quartile hostiles have a mortality rate of 20%. The low hostility quartile has a mortality rate of a mere 2%. So this changed American cardiology. When I was a kid growing up and looking at Mark, people said, well, if you're multitasking all the time and if you're running around from point A to point B like a New York strut, and you're hostile, that's the constellation. But now actually people will say generally it's okay to be multitasking. It's okay to be in a rush. But if after class you go out to the road here where that yellow light is, and the person in front of you has the audacity to slow down, and you fall full chested on your horn and scream out an expletive, then you got a problem. Am I right, more or less? All right. I'm getting verified. Okay. So it matters. This is a beautiful study. It's replicated 48 times. It's the beginning piece in Esther Sternberg's book, Healing Spaces, Harvard University Press. She was the former director of the psychoneuroimmunology laboratories at the NIH and is now at the University of Arizona. This is Paoli, Pennsylvania, the first of these studies. It's a hospital out on the western edge of the main line. And matched controls and subjects wake up after surgery. The subjects have a window with a beautiful view of trees in the distance. The controls have a brick wall. This is like St. Charles. If you're really lucky, you get a window that looks out over the harbor, and you see the P.T. Barnum boat coming in, and you're like, whoopee, But on the other hand, you also get these bricks, So it turns out that the ones who have the view of the trees have shorter stays, less pain, self-reported pain, fewer minor complications, and better emotional well-being. It's been replicated almost 50 times. The Harvard Mastery of Stress study. Here you go. Think about this. 126 healthy men were randomly selected from the Harvard classes of 1952 and 1954. They responded to a questionnaire about how close they felt to their parents. 35 years later, 91% of those who did not perceive themselves to have a close relationship with their mothers had serious diagnosed diseases in midlife, high BP, heart disease, ulcers, alcoholism, as compared to 45% of those who had close relationships. And of course, it applies as well to relationships with fathers. So this is all about attachment 101. It's not determinative. There's lots of studies showing if kids have good non-parent mentors, if they get in the right communities, if they marry the right person, if you ever do. I can say that. They can overcome these kinds of things. But the bottom line is that you have to think about illness with these kinds of dynamics in mind. Emotional benefits, ask a dying person empathically what has meant the most to them in life. This is Dame Cicely's concept. What they want to be remembered for. 76% report heightened dignity, 68% increased sense of purpose, and most an alleviation of stress. Compassionate communication with family members whose loved ones are dying decreases anxiety, depression, post-traumatic stress, and decreases use of the ICU at the end of life. Pre-operative cognitive empathy, sedatives. Tracy, you would know about this. An anesthesiologist. Actually, the bathe technique is used quite commonly in anesthesiology, preoperatively. If you just connect with your patients by asking these kinds of questions, what's going on in your life? It doesn't take more than 10 or 15 minutes. How do you feel about it? What troubles you most about the situation? What helps you handle the situation? And then an empathic statement, this is tough, or anyone would feel this way. Guess what? It lowers anxiety, and it is more effective than sedatives. More effective than sedatives. So this is real. Benefits for clinicians. Sorry to say it, but about 60% of doctors these days are pretty unhappy being doctors. And the major reason, almost 90% say that's the case, is because of the systemic inhibition of empathic care. Clinician satisfaction with patient relationships protects against professional stress and burnout. These are articles in the New England Journal of Medicine, Journal of the American Medical Association. I'm not playing games here, right? Enhancing the meaning of work. Meaning, that's the key thing. What's meaningful? Viktor Frankl, a lot of you crossed Frankl in college. his great book, Man's Search for Meaning. He thought it was the most essential drive in human nature. Is it hard to remember why you decided to become a nurse, a doctor, a pharmacist, a minister in the first place? In Rochester, you've got mindful communication programs involving meditation, self-awareness, appreciative interviews, readings, discussions of meaning, enhanced empathy, caring attitudes, and it all lowered burnout dramatically. So, we have all of this advertisement about patient-centered care, but there is no such thing as patient-centered care without provider well-being, a project that Dr. Michael Roess is working on, a philosopher with us today. Pace, grind, task mentality, late-night paperwork, tethered to an iPhone. I don't know what to say about my smartphone. It's a machine. I'm not. And I can never get away from it. It doesn't care. Pressured on money, no venues to process difficult cases emotionally. This morning in the Children's Hospital, we had another Schwartz rounds where clinicians were able to talk about a case that's 2 years old involving brain death in the neonatal unit. And as Dr. Palmer was there, you'll notice everybody on that panel welled up in tears. So those feelings, even though they're old, they're still there. You need to have a chance to process those things. Reflection rounds in your clerkship environments. And the Stony Brook Med now is beginning a program, retreats for team building. Because guess what? The CEO here has been very clear in stating that patients don't just want empathic care from their clinicians and other staff, but they also want to see it role modeled on teams. They want to see good relationships in the healthcare team. They don't want to see people dissing each other and arguing all the time. You use the word diss, raise your hands. You like it, you like it, you like it. Little anecdote. You have to bear with me. First time I heard the word, my daughter was a third grader. She went to a values clarification class at the Fernway School in Shaker Heights, Ohio. The kids did a skit of Hansel and Gretel. And after it was over, the teacher turned to the children and she asked them, "Children, was the witch right to try to cook and eat Hansel and Gretel?" And some kid waved his hand frantically in the back row and he said, "Yeah, they dissed her by eating on her house." There you go. I said to my daughter on the way home, maybe the witch could have called 911. She said, "Dad, don't judge." There you go. Anyway, some people talk about being a wounded healer as a pathway to greater empathy. Carl Jung really extolled being ill as an experience for clinicians. Seneca said the wounded doctor heals best. I don't know. It's an interesting pathway. We don't all need to get sick all the time. I wouldn't idealize it. I practice it with caution. But it is interesting. And physicians who become patients do sometimes go through transformations. Benefits for students. These are the lymph nodes. How many of you are joining the lymph nodes? I love the lymph nodes. Big lymph nodes fan. This is them coming back from the cancer center across Pellegrino Road over here to the lobby, having sung songs for the cancer patients. It looks a little bit like Abbey Road, if you remember the Beatles, which none of you do except for my old friends. But you look at all the joy and the happiness there. Seek balance. Join the Astonished Harvest, the poetry organization of medical students that Dr. Bronson and Dr. Coulihan are so involved with. Poetry, music, narrative, medicine, dance. The very word medicine comes from the root medi, or balance. Same thing with the word for meditation. Medicine, meditation, balance. Even consider a little hot yoga if you're interested in 90 minutes and 110 degrees. Just kidding. Compassion, resilience. Medical students in this national survey point out that they do find resilience and energy in having compassionate, humanistic attitudes, and they get that most often through caring for dying patients, through volunteer work, through international rotations, and through positive role models. Benefits for organizations. It takes about 10 years, they say, in management school to change the reputation of an institution. We now here at Stony Brook, but all across the nation, have these interesting little questionnaires that get sent out randomly to patients upon discharge, the Hospital Consumer Assessment of Healthcare Providers and Systems, HCAHPS. And it asks basically 21 questions. They're identical groups of 7 questions addressed to the doctor, your self-reporting, your relationship with your physician, your nurse or nurses, and other staff. And the questions: were you treated with respect? Were you treated with care and empathy? Were you communicated with well? Were you satisfied with your interaction with your provider? And guess what? Medicaid and Medicare reimbursement is now prorated at 3% based on HCAHPS scores. And next year and the year after, it's going to go up to 5 and 6 and 7. And that means that institutions which don't have a large population base of privately insured individuals really are in trouble unless they get their HCAHPS up. And that's really pretty interesting. That's why 35 healthcare systems across the country are now having empathy training for residents and doctors. And when you go in your residencies these days, I guarantee you a 50% likelihood that you will have to go through empathy training because it's bottom line. And I don't mind it. It also, of course, good empathic physicians avoid medical errors because they're more diligent on the whole, and also legal suits are avoided. So about a year ago, Ken Kashansky here had a big meeting in the Galleria, and all the department chairs were there, and everybody and anybody. And he basically said, look, we have to create an environment of empathy and compassion clinically, or we're in real trouble. Because again, Stony Brook is very dependent on Medicaid and Medicare. And it's got to be seamless, from the CEO to the receptionist, from the clinician to the custodian to the valet. So I talked a little bit about empathy and compassionate care. Look, I mean, we all have a little bit of a cynical side in us. I do too, believe it or not. The thing about empathy is that it's easily overwhelmed. Too much obedience. Stanley Milgram, Zimbardo, the Stanford Prison Experiment. They basically tell you that if you take 90 people and ask them to inflict lethal shocks on innocent individuals in obedience to authority in the laboratory environment, 2/3 of them will do it. They may feel a little uneasy afterwards, but only 1/3 will vote with their feet. Right? So that goes for all of us. Right? Be a little irreverent. Respectful but irreverent. Sometimes I talk with med students in clerkship environments, and they ask in these reflection rounds, I felt that I had to laugh at this foul, demeaning joke that made fun of an innocent patient. I didn't want to laugh, but I felt that I had to laugh because it was expected of me. What about my integrity? So people think about this. It's deep, It's deep. You don't want to be irreverent, but disrespectfully. But sometimes you need to hold the line. Too busy, seriously. So Dan Batson, probably the most famous researcher on the empathy altruism axis in America at the University of Kansas, he did a great study. He went to Princeton Theological Seminary, and he had some minister do a long sermon about the Good Samaritan story. In the meanwhile, he had paid some actor to be on the pavement out in front of the chapel, moaning and bleeding ketchup. And several hundred students walk out from the sermon, and only about 15 of them actually stop and talk with the guy. And later on, Batson asked them, well, why didn't they stop? And they said, we had to get the class. We had to get the class, That's a problem. But it's also human nature, and it's called the bystander effect. Arrogance, self-inflation. A lot of studies now are showing that humility leads to empathy and compassion. Lots of really good studies in leading A-level psychology journals. We do have blind spots. The problem of indifference and resignation. Yes, Billy Joel, the world's been burning since the world's been turning, but still try to make a difference, okay? For some people, the source of that difference is spirituality. I don't know where you fall on this. I don't know where I fall on it. This is Chagall's UN windows that were done after the death of Dag Hammarskjöld. When I was a kid, my mother took me in to see those. He was an amazing artist, and he spent his whole life trying to describe the power of compassion in his art. Slip sliding away, people debate definitions, but basically professio comes from Latin to profess, which means to publicly state commitment to an equal, identifiable constituency through a public oath. End of story. And it's different from careo. It's okay to have a career, Look, food on the table, good thing. But don't ever have a career if you don't first focus on the needs of that constituency. And of course, occupare, just filling up the day, occupying space. I think a lot of folks, on any given day, they may be a little emotionally exhausted or whatever. You can sort of slip into careo, slip into occupare, but you always want to be committed compassionately to the good. One of our med students 5 years ago, a kid named Jeffrey, we had our first MCS section. We asked the students, what do you fear most about becoming a medical student? He was the last one to respond, and he said very slowly in an incredibly deep voice, he said, I fear being slowly digested by an immoral universe. I laughed. So you got to watch out. Just the careerism. I mean, look, all the Nazi doctors said, well, we were doing what we were told. We were just following orders. What does this have to do with ethics? Somebody asked me that the other day. I couldn't believe it. The answer is everything. Where does ethics come from? Well, some people say it's all pure reason, like Kant. I've never seen pure reason. I hear a lot of rationalization every day, but not much pure reason. And even if I thought I saw it, I'm not sure it would motivate anybody to act. Some people think ethics comes from just enlightened self-interest, the world is a nasty, brutal place, Hobbes' state of nature. So for us to just live together all peacefully, we need to have certain restraints on wanton behaviors like violence and deception. But those things slip away. Have you noticed the political arena these days? Truth? What is truth? Sorry, but I'm just being honest with you. Utilitarianism, greatest happiness of the greatest number. Who's defining happiness? Who's imposing it on who? Good role modeling. I like this. Good is in the details. There's an Entenmann's bakery truck going around 25A, and it's got a nice sign under a cake. It says, good is in the details. And it is. You want to learn from good role models. It's really more about passing the torch or transmission than having some fool like me stand up here and give a presentation. Be honest. And you'll see it, again, in the details. The empathy-altruism axis, I think that's really the core of all human morality and ethics. If that isn't there, I don't know what we have. There's the analogical imagination. In clinical ethics, people don't think in linear terms. They don't deduce from principles. They compare case A to case B and how this new case is different or similar to those two. You'll hear about that next time in the discussion on how ethical reasoning is pursued. Virtue, wisdom, and moral luck. I kind of believe in this. Aristotle said there is no principle of ethics. It doesn't exist. There are virtues. People can be courageous, honest, trustworthy, caring, and so forth, and give them a lot of experience, in this case in a clinical environment, and let them make choices collaboratively with patients and just trust in luck, because you never really know prospectively if any moral choice is right anyway. It all comes downstream, and you look at the effects. Did it work? Didn't it? Maybe it looked like it worked one day, but then a week later, it doesn't look so good. And then, of course, there's Chagall's blue air, if you're a mystic. I don't know. But where do these things come from? To me, the core source of all ethics in moral life is empathy, altruism, compassion. P4 Berlin, quick comment on this. Tiergartenstrasse 4, 4th Street in Berlin, when 70,000 people with cognitive disabilities were taken out of German asylums. And these were not, by the way, Jews, gypsies, people of color, the normal discriminated against groups. These were Aryans. Half of them had probable dementia. They were defined as life unworthy of life, talk about microaggressions in language. They were defined as useless eaters. There's a microaggression. They were left to freeze, 70,000 of them, in vats of ice water or out on the snow, freeze to death. And then they were brought back into the asylums, and they were thawed out in hot water at different temperatures, sometimes boiling hot water, sometimes mildly warm water, in hot air and the like, to see if they could be thawed out, which they couldn't be, of course, and the Germans justified this. They were following orders, the doctors who were in charge of this, Schallmeyer and others, because the government said we need to find out at what point it becomes futile to send rescue teams into the cold waves of the North Atlantic to save downed flyers. Well, even the German people got sick of this after a year and a half, but the same doctors moved straight to Auschwitz and Dachau and perpetrated the hypothermia experiments and other experiments, primarily on Jews, but others as well. When they defended themselves at Nuremberg, and we'll talk a little bit about this in a month or two, they said we were following orders. And of course, we in the United States have Tuskegee. So reason to hope. You know, you're reading a book in this course by Jerome Groopman, a great clinician, called The Anatomy of Hope. How many of you have ordered that? It's a good book. It's not, hard to handle. It's a guy who's really talking from experience. It's deep. I love this book. I think it's the finest book ever written on the subject of hope by anyone, clinician or non-clinician. Because hope is the elevating feeling we experience when we see in the mind's eye a path to a better future. Hope, I have come to believe, is as vital to our lives as the very oxygen that we breathe. Each disease is uncertain in its outcome, and within that uncertainty, we find real hope. Because a tumor has not always read the textbook, and a treatment can have unexpectedly dramatic impact. This is the great paradox of true hope. Because nothing is absolutely determined, there is not only reason to fear, but also reason to hope. So be a rose in the desert, as they say, no matter what your environment. Treat people with empathy and compassion. Bring hope to their lives. And seek a little balance. I have to say, I took this from Dr. Goulahan's slides. He showed this the other week. This is a matter of just continuity. I actually am okay with House. Sorry, I'm okay with House. Because I think he's burned out, But I think he's burned out partly because of the system. And obviously he doesn't have much balance in his life. But, he is irreverent as hell. And he has to be, because sometimes that's what he's required to do for his patients. I like the one House clip that Dr. Malbin showed in his class last year, where there's a young intern who has actually engaged in an act of assisted suicide at the request of an experienced clinician who knows it's straight downhill. Nobody knows that it's her, but House figures it out, and he goes into the chapel in the hospital and puts his hand on her shoulder and is compassionate. So he's not too far out, okay? I'm going to end here and just ask if we have any thoughts, comments, questions. I threw out a lot of stuff, probably too much stuff, but some of you can help us out. Okay, who's first? Yes, sir.
So in the readings and at the end of the lecture, you both mentioned the persistence of hope, even when the probability of a cure is low. There's always diseases don't always follow the established trajectories. There's always some chance of it being curable. And that's also very how the book handles it, that there's always a chance, and doctors should encourage their patients to embrace that chance. Do you think there's ever a point where it is sensible, a decision you would agree with as someone's physician, to not pursue something? Do you think sometimes, the cost of the rigors of chemotherapy are too high, and you would say it isn't worth it?
Well, in conversation with patients, absolutely. Groopman's point is don't ever create false hope. For him, it's all about truth. But he thinks when you are truthful about the facts, the prognosis, the numbers, of course they are generalizations and there are exceptions. But when you're truthful, there's always reason for hope. So never dash hope, and hope can be redirected. You can guide people into new forms of hope, like Chagall's windows. More spiritual forms of hope, or social forms of hope, or reconciliation. There are high mortality rates in hospitals around the holidays because people wait to die so they can get together with their loved ones on vacation. It's interesting. I mean, you have to be very careful not to manipulate with hope, and it's a very easy thing to slip into. I would be careful and cautious about ministering to hope. I think you have to be very, very thoughtful, and it's a part of what an empathic clinician learns to do. They just learn how to handle hope, and even when you have to, sort of help someone to redirect a little bit, you do it empathically. You do it empathically, so it doesn't feel like a steel hammer. It's more like a velvet hammer, if you will, and there is a difference. But it's a skill set, and it's an important one. Someone else? Please, yeah.
What do you think is the largest barrier in physicians and medicine being more compassionate, and how do you think we can overcome that?
Well, there are a lot of people here who would have thoughtful responses to that really excellent question. It's pretty much all of the above. It's the microaggression issue. In your clerkship years, you'll have a whole session, actually in preparation for residency, a whole session on microaggression, on the little biases that are pretty wired into us as in-group versus out-group and so forth, and how to be self-aware of those things. I think that's important. I think that being thoughtful about hierarchical structures and role modeling is really key. There is actually a session in this course, the very last session, is on role modeling, and you'll hear from your peer students who are in the clerkship years about their experiences with some very wonderful, uplifting role models who inspire them to compassion, and then some real dastardly ones, like the guy who walks into the patient's room in shorts, sneakers, with his golf bag over his shoulder and says, "I can only give you 30 seconds." I mean, the point, though, is that you learn how, they always say, we learn a great deal about how we don't want to practice medicine from those kinds of role models. And I think you have to have some courage. Gandhi said that compassion is for the brave, right? Doesn't mean you have to be a pain in the neck and so forth. But, where you see situations, you have to use your creativity and try to inject some compassion, be able to correct people in a way that is constructive. So there's a lot of things to be said about that. It's a really deep question, but it's a terribly important one. A couple of others? Yes.
And one thing that I just wanted to say is that for medical students, I think that not only medical students, but all of us in our day-to-day lives, we get caught up in this whirlwind of things to do, and we forget to take a moment to stop and to think. One of the things you mentioned was meditation, but I think also, and I know it's used a lot, so I don't mean to use it again, but the concept of reflection is not a small thing. And if you find yourself getting caught up in this whirlwind and you think you don't have time to be compassionate, you think you don't have time to feel or think kind of the right way, I think that reflection is very, very helpful because it stops the clock for a moment. It makes you think carefully about why you're here, why you're doing what you're doing. And I don't think it can be underrated or overrated or whatever. I mean, I guess overrated is the way to say it. So think about that. Think about the reflection, the concept of reflection, and how it can really help you as doctors.
I really like that statement from Marilyn London because, time is chronology. You're always worried about where you fit in time. Of course, if we study quantum, we're not sure about the existence of time. But that aside, it's a little irrelevant, not entirely. The point is when you meditate, when you reflect, you're stepping out of time. You're stepping out of chronos. You're stepping in more to the now or into what the theologians call kairos, or sacred time. That's a time when you can just reflect. Just reflect. Step back, pause, and reflect. And we do that in your clerkship years. As soon as you get into primary care, OBGYN, pediatrics, you will have reflection rounds every couple of weeks where you just sit with a small group of 6 or 7 of your peers and you reflect on the things you've experienced. And it's incredibly beneficial. And if you can get into that habit early on in your careers, I think you will not turn out looking like House. I think you need to build these reflective skill sets. So when you have an opportunity in a course like this or in time or whatever to write a reflective essay and to engage in this kind of activity, it actually is a real lifesaver for you. Anyone else? Yes, sir.
So obviously there's a competitive aspect to medical school. For instance, we're all ranked according to our quartiles. To what extent do you think that inhibits our ability to be compassionate?
Competition, ranking, it does. It does. You know, Jefferson Medical College in Philadelphia, by the way, is now using a screening tool for all its applicants. It's called the Hojot Empathy Scale. So in addition to being a good student with a high GPA and so forth, et cetera, they're actually using this as a primary screen. I think that to some degree, we need to think about people coming into medicine. A lot of folks come into medicine from the humanities. They may pick up biochem in a summer session, but there's something about the art of medicine, the art of healing, which is more than science alone. Science is incredibly important. We all love science, but there's more to it than that. So the competition side, I think, does create probably certain kinds of inclinations that are, in most cases, pretty deeply part of your experience long ago because you had to work so hard. And thank you for getting here, for getting to this point. But still, you know, you want to think about it reflectively and realize that there are deeper realities. The primary one being compassionate care to one another and to your patients. I really like the idea. I was talking with Pasternak about this, that they're developing these empathic team leadership modules for the faculty and clinicians here at Stony Brook. That's really important. And that the patients in these responses to Stony Brook have identified that as something they really want and expect. I think that really tells you something about what's important. Okay? Someone else? Okay, Mark, and then we'll wind up.
Just to answer your question as well, Dr. Post and I had a conversation about that. And I think the pressures of competition in medical school, can be healthy, but I think what happens is you lose sight of the fact that you're in this profession for someone else. And when medicine becomes something about advancing yourself in your career and getting the most, competitive specialty, I think the outlook or the purpose of your pursuits becomes something that is about yourself, and you lose sight that all this intellectual development is ultimately to give way to the service of others. So I think that's something that why reflection is so important. You have to keep sight of the reason why you're going through all this training is not for yourself, but it's for another person. And if you can look at that outlook, when you can have that outlook, I think competition becomes something that's secondary, and you find a lot more fulfillment and motivation to learn about empathic care.
Okay, well, Jeff, and then we'll wind up.
Just to add to that relevant point,
Dr. Trilling.
I think that you cannot be compassionate until you have compassion for yourself. Now, if medical school competition affects your self-esteem, if you're in a lower quartile and you look in the mirror and you see somebody there that you can't feel compassion for, you're not going to have enough compassion in you to share with your patients. So it's a question of balance that's up there. The love sucks, I don't agree with, but having a little balance in your life is really important. And have to learn to have compassion for yourself.
You have to grab it and take it, because not everybody's going to give it to you. Okay. I just want to thank you for listening in, and have a good session. Thank you very much.